Hello, good evening friends. I am Dr. Samiksha. I have recently passed my MD Microbiology from Bangalore Medical College, presently working as senior resident in KIMS Bangalore. I would like to restart my microdoc SAM classes. So I would like to start with the topic histoplasmosis today. Firstly, I would like to discuss a case of 48-year-old male, not a known case of HIV, came with history of low-grade fever, weight loss, decreased appetite, worsening breathlessness. On examination, there was presence of hepatosplenomegaly and in laboratory investigation, findings showed anemia, leukopenia, rise in ESR, and in CT also it confirmed the presence of hepatosplenomegaly along with adrenal mass presence. FNAC of adrenal mass showed growth of fungus which is having both yeast and mycelial phase. In GIMSA staining also, that thick and thin smear, there was presence of intracellular yeast. So here actually if we look at the case, it looks like a clear-cut case of disseminated tuberculosis. So initially the diagnosis was missed and the patient was treated with anti-TB drugs. Patient did not improve for around 3 months and then histoplasmosis was suspected and repeat sample for adrenal mass sample was taken for fungal culture and then proven to be Histoplasma capsulati. This is a case report from Himachal Pradesh. Histoplasmosis, even though there are around 8 different clades, but 3 varieties based on different species. Histoplasma capsulati, which is most commonly seen in USA and it is endemic to southern part of USA, although it is distributed all over the world. Histoplasma duboisi, again it is most commonly distributed in Africa, and Histoplasma farciminosum, actually it is rare, not seen commonly in humans, but it affects horses. Coming to epidemiology of histoplasma, actually it does not affect birds and it is not present in bird droppings, but bird droppings or bat droppings mixed with soil, fertilizing the soil along with humid condition is the best combination for growth of histoplasma, and histoplasma occurs in filamentous form in the soil, which is different from how it occurs in vivo or in vitro, that is yeast or mycelial form. But in soil which acts as a reservoir, which spreads from man to animal spread is very rare. So it spreads from man to man from soil. So it occurs as filamentous form. So as already told, they occur as filamentous form mostly in the soil reservoirs, which are also interchangeable to mycelial or yeast form. In mycelial form, as you already know, that it can have macroconidia and microconidia. As the name says, microconidia is smaller in size and hence can pass to the lower respiratory tract and reach the alveolar macrophages. How? By inhalation. So after getting phagocytosed by alveolar macrophages, the mycelial form, that is microconidia which entered, will get converted to yeast form, which is intracellular form, and then get disseminated to reticuloendothelial system, very important in histoplasmosis. Other parts like cutaneous, it can get also to bones, GIT, even to ophthal. So in ophthal it is called as presumed ocular histoplasmosis syndrome. So POHS. So various important clinical manifestations includes acute pulmonary histoplasmosis, chronic pulmonary histoplasmosis, mucocutaneous histoplasmosis and disseminated histoplasmosis. Acute pulmonary histoplasmosis is almost similar to any acute pulmonary presentations of lower respiratory tract infections. Like it will have fever with chills, dyspnea, dry cough, headache, malaise, etc. On radiography, there can be pulmonary infiltrates with hilar lymphadenopathy. See, chronic pulmonary histoplasmosis will have additional symptoms like loss of weight and hemoptysis also. So, which is a common symptom of tuberculosis. So, it is a great mimicker of tuberculosis, has to be remembered. And along with that, mucocutaneous presentation, which is unlikely in TB, like oral lesions, skin lesions can also be there. Along with that, GI involvement can be there. On radiologically examination, there will be cavities present, especially apical and subapical, which is also common in TB. And you can see that initially 2 to 3 whatever macrophage with yeast is there, which becomes fully granulomatosis around that, and also which can become fibrosed and later converted to calcifications. These calcifications can be confused with any malignancies because of appearance like a mass lesion, and also you know that it is like alternative diagnosis is tuberculosis. Cutaneous histoplasmosis is most commonly in abdominal walls or thighs, appearing as plaques or erythematous purpura, but it is the major presentation in case of histoplasmosis duboisi. Cutaneous histoplasmosis as a direct presentation, it is very rare in histoplasmosis capsulati. So in disseminated histoplasmosis, actually it is most common in children less than 2 years in immunocompromised or post-transplant cases. They present with other symptoms very important like hepatosplenomegaly, GI symptoms like loose stools can be there, blood in stool can be there, and already discussed, presumed ocular histoplasmosis syndrome showing atrophic histospots, and also in laboratory findings like anemia, leukopenia can be there. So general symptoms like fever, anorexia, weight loss, which you already also seen in chronic cases. So it can overlap, and all chronic cases can progress to disseminated histoplasmosis. Coming to differentials, so tuberculosis, as already discussed, it is one of the most important differential for histoplasmosis and vice versa. And you should know that systemic mycosis is caused by histoplasmosis, blastomycosis, coccidioidomycosis and paracoccidioidomycosis. So each one of them will have differential for each of them. So for histoplasmosis, we can have other differentials like blastomycosis, coccidioidomycosis and paracoccidioidomycosis. Other intracellular pathogens like leishmaniasis can also be another differential. Pneumocystis jirovecii in case of immunocompromised state is important differential, and as already discussed, it can mimic sometimes the masses like malignancies. Coming to lab diagnosis of histoplasmosis, the microbiological diagnosis I am discussing in detail. That is, samples includes tissue biopsy material, or it can include other samples like bile fluids, sputum, bone marrow aspirate, peripheral blood and lymph node aspirate, or FNAC guided biopsy of lymph nodes. So actually biopsy material, tissue is the best sample to isolate most of the microorganisms, which holds good for histoplasmosis also. So for rapid identification, direct microscopy is also done, whereas culture is the gold standard. As already known, culture is the gold standard for most of the microbiological diagnosis except for few. Now, in direct microscopy, KOH actually, in KOH the problem is there is high chance of missing the identification, missing the organism, as the if they occur in yeast phase, they have narrow base budding and they are very tiny also, around 2 to 5 micrometer. So there is a chance that it will be missed. So like how we do for leishmania or for malaria, thick and thin film can be done and Giemsa stain can be used, in which intracellular yeast cells will be like easily identified. Then other things like PAS or GMS stain can be used. H&E stain can also be used. So in histoplasmosis, there is narrow based budding of yeast cells, and in blastomycosis there is broad based budding of yeast cells. And mycelial phase, how it will occur, I will explain. In mycelial phase, there will be spherical macroconidia with multiple tubercles all over, and microconidia are usually oval, occurring along the hyphae. So there is branching, septate branching hyphae with the macroconidia and microconidia. But even though in direct microscopy it is very rare to get mycelial phase, but in vitro, in culture, while we grow, it can be identified. Yeast phase, you can see narrow based budding yeast cells of around 2 to 5 micrometer. Exception is in Histoplasma duboisi. In Histoplasma duboisi, yeast phase yeast cells are more bigger, that is, it can be 7 to 20 micrometer, up to 7 to 20 micrometer. Coming to culture, which is the definitive diagnosis, and as you all know, dimorphic fungi takes longer time to grow, like around 6 weeks, except for Coccidioides immitis. Then samples are inoculated in plain STA with actidion, and other media like BHI with blood agar, which is very good for mycelial to yeast or yeast to mycelial conversion, and other media which can be used like Kynes medium. So all are incubated, one set at 37 degrees Celsius and one set at 25 degrees Celsius. 37 degrees Celsius is for yeast phase and 25 degrees Celsius is for mycelial phase. The list of dimorphic fungi is actually big, which includes histoplasmosis, blastomycosis, coccidioidomycosis and paracoccidioidomycosis, sporothrix species which is causing subcutaneous mycosis, Telleromyces marnefi which is causing opportunistic fungal infections, then two mucorales from mucorales family, two species like Coccieromyces recurvatus and Mucor cercillinoids. So it is 8 organism actually, dimorphic fungi. It's not a short list. So just note this. In future, I will be discussing about other species too. Coming to other diagnostic modalities, like there is immunodiffusion test, in which, see here in the center there will be antigen. The antigen can be histoplasmin or whole yeast cell, methylated whole yeast cell. So here we will be also inoculating patient sera along with positive and negative control. Then it shows which type of immunodiffusion. Actually it shows double immunodiffusion in 2 dimensions. Another example for this type of immunodiffusion is Elix gel precipitation test in diphtheria. So actually immunodiffusion is a type of precipitation reaction, and in diphtheria we will be using in the center antisera and we will be inoculating antigen. Here it is other way around. Then other tests like complement fixation, enzyme immunoassay and DNA probes using of this is most confirmatory. Even though these tests may not be needed if culture has come positive, but it aids in the confirmation of the diagnosis during the early days, as culture will take longer time to grow. Coming to treatment, it is given as induction therapy and maintenance therapy, just like how we do in cryptococcosis. So induction therapy, we will use liposomal amphotericin B, which is having good response, given 3 mg per kg per day as IV and slow IV, and given for 2 weeks, except in case of CNS involvement 4 to 5 weeks. It is given for 4 to 5 weeks. Maintenance therapy is itraconazole, which is 200 mg TID dose for 3 days, which will be changed to BD dose and given for almost 12 months. Thank you. So when you are given a question on histoplasmosis, in PG exam, theory exam, you will be given only 5 pages. So you can cover it this way. Epidemiology and pathogenesis can be covered over a flow chart in 1 page. Clinical presentation with you should put arrow mark and divide the 4 types, explaining each type in brief for 1.5 page. Laboratory diagnosis, again you will be telling about sample collection, then direct microscopy, culture and other diagnostic modalities, covering in 2 page. Treatment just covering in a half page. So this will be your plan for writing in theory exam. So here I have covered histoplasmosis, and in further videos I would like to cover other systemic mycosis causes and other dimorphic fungi. to complete dimorphic fungi. Please like, share and subscribe, and leave comment and give feedback on improvement. Thank you.